Welcome back. Our next case is called Carol's First Bad Day. By the end of this podcast, you should be able to list the common features of proximal humerus fractures. This is Carol, a 59-year-old right-hand dominant woman who tripped over a garden planter at a wedding this afternoon and landed on her outstretched right arm, an injury commonly called a fouche, fall onto an outstretched hand. She's got pain in her right shoulder. Normally, she works in an office, has high blood pressure, and has smoked half a pack of cigarettes a day for 40 years. By way of reminder, think through what you've learned from Devin's story. For efficiency, we're not going to go through the whole list, but it's a good exercise. However, we're going to jump straight to the missing bit. We need to think about glenohumeral joints and proximal humerus fractures. Proximal humerus fractures are tremendously common, with the classic patient being a middle-aged to elderly female. These can be isolated fractures or can be part of a fracture dislocation. People talk a lot about parts, but in essence, there may be a head fragment, a greater tuberosity fragment, a lesser tuberosity fragment, and a shaft fragment, or any combination of these. Almost all are treated without surgery, and almost all people have a permanent reduction of function in that shoulder, usually manifested as stiffness. Proximal humerus fractures are also classed as fragility fractures, and in the middle-aged to elderly patients, especially women, this should trigger a discussion about bone health. So after you assess Carol, there are no concerning features at her AC or SC joints, or lower on her arm. The shoulder is painful, but there's no fracture on the radiographs. You send her away to follow up with her family physician. By way of review, proximal humerus fractures are common, potentially disabling, and most commonly treated non-operatively. They most commonly result from low-energy mechanisms such as a fall from a standing height and may signal the presence of low bone mass or osteoporosis. This is where we end for the core material on Carol's first bad day. However, her story continues into bonus time. Stop the playback here if you like. If you're interested in continuing, especially if you're in a primary care setting, sports medicine, or other MSK-related clinical situation, we'll explore a couple of other classic shoulder conditions. So Carol returns to her family physician a couple of months later. She's maybe a little better, but she's still struggling. We've been spending a lot of time talking about bones and joints. There are other layers that could be causing a problem here. Let's look at them now. Soft tissue problems of the shoulder can arise from injury, like Carol's situation, or be atraumatic. This is the list of grab bag soft tissue issues arising around the glenohumeral joint. When her physician examines her, Carol has a reduced active range of motion in all directions with pain, and her passive range of motion is also reduced. Her strength is not bad, but it is less than her left side, likely because of pain. How can we sort this out? Radiographs are great for imaging bones and joints, but they don't help us with soft tissue problems. Ultrasound and MRI may be used to diagnose soft tissue problems around the shoulder. Ultrasound is best for more superficial structures, is easy to obtain, and inexpensive. The downside is that the quality of examination can be variable. MRI is very detailed and less operator dependent, but it's expensive and difficult to access. The most efficient imaging for these situations is a good set of radiographs and an ultrasound exam that gets interpreted in the context of a careful history and physical exam. We know there aren't any problems with her radiographs, but her ultrasound shows only a possible thickening of her subacromial bursa. So what's left on our list? Well, we've got adhesive capsulitis and subacromial bursitis. Adhesive capsulitis is a strange condition in which the capsule of the joint spontaneously becomes very thickened and fibrotic. Instead of having enough volume and compliance to allow the glenohumeral joint to move, the thickening of the capsule and change in material properties fills the volume and tethers the glenohumeral joint. It does tend to affect women more than men, usually in middle age, and is more common and harder to treat in patients with diabetes. Lots of things can make a shoulder stiff. Adhesive capsulitis is by definition a stiff shoulder in the absence of demonstrable structural pathology. Getting this right is important to providing appropriate and timely care for patients. Rather than calling all stiff shoulders frozen, Take it to the next level and call it what it is, whether it's arthritis, capsulitis, post-traumatic contracture, etc. Looking at the other diagnosis on Carol's differential, we come to subacromial bursitis. There's quite a bit of overlap between this and the rotator cuff syndrome podcast. The key feature is the painful arc with a sharp bite of pain around 90 degrees of forward elevation or abduction. Non-operative treatment, similar to the treatment staircase for rotator cuff tears, is the way to go here. Some well-done recent randomized controlled trials have shown that surgery doesn't offer benefit over a good non-operative program. Related to this is calcific tendinopathy, which is another oddity in the soft tissue grab bag. We're not sure why this happens, but the body starts depositing calcium in the rotator cuff tendons, and that calcium becomes acutely painful for some reason. It'll present very similarly to subacromial bursitis, but the calcium should be visible on radiographs. It's treated very similarly to bursitis and rotator cuff syndrome, and usually resolves with time. Interventional radiology or arthroscopic surgery can be considered to evacuate the calcium deposits. So let's drill down into the treatment staircase here. You'll likely be noticing some common themes again. We've decided that Carol likely has an adhesive capsulitis given her global reduction in both active and passive range of motion and her essentially normal imaging. The lower steps are the same as for rotator cuff syndrome. The unique features here are the capsular distension injection and the surgical release. The point of the injection is to blow a hole in the capsule, allowing the glenohumeral joint to move again. With surgery, the idea is to cut through the thickened capsule as much as you can and then rupture the rest with gentle on-table manipulation. If we're looking at the alternative diagnoses of bursitis or calcific tendinopathy, very similar steps, except instead of a capsular distension injection, the radiologists can do a needle lavage, where the deposit is broken up with a needle and flushed under image guidance. I can also go and debride out that calcium deposit, which most of the time isn't necessary. So Carol and her adhesive capsulitis grumble along for a while, but eventually things get better. It takes about 1.5 years, but she's up and running now with a nearly normal shoulder. So that's it for Carol's first bad day.